Welcome everyone to our speaker series event today. Thank you all for attending. We have the privilege of hosting Peta Alford, the Nurse Unit Manager of the Specialist Palliative Care Service in the North. We thank Peta sincerely for her time, insights, and for joining us here today. We would like to take a moment to also acknowledge the Palawa Pakana people as the original custodians of Litchfield, Tasmania. At Palliative Care Tasmania, we acknowledge the Palawa people's deep connection to family and community, and their enduring strength and compassion in caring for their sick, dying, and grieving. I would also like to pay my deepest respect to the elders past and present, and extend that respect to any Aboriginal or Torres Strait Islander people that may be joining us today. Before I introduce our speaker, just some basic housekeeping. We will have 15 minutes at the end of the presentation for questions. However, if you do have questions during the presentation, please pop them in the Q&A function at the bottom of your screen, and I will ask Peta during the presentation. If you do have a question, please take a moment and pop it in there. So without further ado, it is my pleasure to introduce Peta Alford. Peta Alford has been a nurse for 18 years, specialising in intensive and critical care. After reaching a point of burnout and feeling uncomfortable with how end-of-life care discussions and care were approached in the critical setting, she transitioned into palliative care with the Specialist Palliative Care Service in the North. Peta recently became the Nurse Unit Manager after working as a clinical nurse consultant for 5 years. She's passionate about client-focused care, supporting carers, and advocating for primary health in Tasmania. Please join me in a warm welcome for Peta Alford.
Thank you very much, Luke, for the welcome. I'm just going to share my screen here with the slides. So I wanted to present today a little bit about what palliative care is in Northern Tasmania, particularly specialist palliative care. I also would like to thank Luke for the acknowledgement of country, and as a service we would also like to acknowledge and pay respects to the original owners of the land on which we live, work and dream right across Litchfield or Tasmania. We pay respects to their ongoing custodianship of the land. We also acknowledge and pay respects to Tasmanian Aboriginal people, elders past and present. So to talk a little bit about the purpose of the presentation today, which is to provide a bit of an understanding of what palliative care is. We're going to talk a little bit about that, plus services that are offered through the Specialist Palliative Care Service in the north of Tasmania. And we'll also touch on some of the differences between what generalist and specialist palliative care means, and some of the referral pathways, and go through a little bit about palliative care ongoing, I guess, across Tasmania and particularly in the north, which is my area. So specialist palliative care services, they exist for people with life-limiting illnesses that have particularly complex needs. There's been an increased demand for palliative care services generally and nationally, indicating that palliative care is everyone's business and should be available for all people. In a variety of settings, we are expected to provide good palliative care and a palliative approach to care, which is essential. And we want to ensure that everyone has the knowledge and skills required to provide that good palliative care in whatever setting they are either working in as a professional, as a carer in the community. There's lots of variations on that. And when we say palliative care is everyone's business, we're not just talking paid professionals, we're talking communities and carers, etc., across everywhere in the community and healthcare. So some of the learning, I would like to also acknowledge in this that our educator, Alice Gardner, also had a lot of input in these slides. And it is some of the education that we provide. So I've tweaked it a little bit to sort of focus across a general population plus healthcare workers. Yeah, so I would really like to acknowledge the work she's put into this as well. So we really want to work on the key concepts of palliative care, understand some of the services that we provide in specialist palliative care, plus the community in the north. We also wanted to identify some of the resources and where to access some resources regarding palliative care, and identify some of the times when palliative care is required. So usually as part of these presentations, we're in a room with a group of people and it's a little bit more backwards and forwards. So we do like to ask the question is, what is your understanding or what do you think when you hear palliative care? Because everyone has a little bit of a different instant reaction to the words palliative or palliative care. I do love this little picture because it sort of pulls together some of the holistic nature of palliative care. I'm not going to leave it there too long, but really, I guess the focus is that it incorporates a whole, and that's a whole group of people, a whole person, and a whole cohort of care providers. We've got the classic definitions. World Health Organization is that palliative care is an approach that improves quality of life of patients and families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment, treatment of pain and other problems, physical, psychological, and spiritual. And then we've got Palliative Care Australia's definition being palliative care is person and family-centred care provided for a person with an active progressive advanced disease who has little or no prospect of cure and who is expected to die and for whom the primary treatment goal is to optimise quality of life. I personally prefer that one a little bit as far as the wording of it. So firstly, and this is where that question of what does palliative care mean to you or what do you think when you hear palliative care is to sort of disband some of the primary myths that palliative care team seems to bring up to most people. The first one, and I think it is the core one, is that a lot of people think palliative care is for the dying phase. And so when you refer to palliative care or if you use the word palliative care, it is actually at the point of death. So I would like to very strongly say that that is absolutely not our core business. The terminal phase or the end of life phase is actually the bit that is probably less about the palliative focus. Of course, we want a good death and we want comfort and we want all of those things, but really it comes back to the point of diagnosis. And it's also the living with the illness. So palliative care itself can be provided across any stage of the experience after diagnosis. There's so many factors that come because there's so many diagnoses that do incorporate palliative care. And this is an ongoing care for patient and their family, which includes bereavement care and post-death support for family. Once again, we're talking about this as a whole group and that the whole patient incorporates those key people that are important to them. The second one is that palliative care is often associated with cancer. Obviously, that is quite a high core group of people that we do have input with and healthcare providers do look after. But we've got quite a few others that we are commonly seeing and are commonly referred to our service. So we've got things like heart disease, respiratory disease, dementia is becoming more and more prevalent, degenerative neurological diseases. So we're talking things like MND, muscular dystrophy, cystic fibrosis, which falls under respiratory, but also your cerebral palsy. There's lots of different ones, MS, chronic liver disease, we've got chronic kidney disease, other degenerative illnesses or significant deterioration. And I would really like to point out that often it's a combination of all of these put together at times. We are certainly seeing a lot more comorbidities and a lot more mixtures of diseases, chronic and acute. And really the core point is that palliative care is and should be available to all people living with life-limiting illnesses, regardless of what the diagnosis is. The third myth about what people assume palliative care is about is that it's mostly about managing pain and other physical symptoms. Of course, that is definitely part of it because we're looking at quality of life and comfort, but really the core purpose and philosophy of palliative care is to help people live their lives as actively and comfortably as possible, and really with a core focus on what's important to that person. The approach to care responds to the needs, experiences, preferences and care requirements of the whole person. And I say they're important people, but let's just say in this presentation, if we're talking family or care, it's the person that is most important and is the core group of people surrounding that client or patient. So the focus is on actually managing distress. This could be distress of a physical symptom, could be a spiritual symptom, psychological, emotional, It is about providing comfort and holistic support to the patient and their family or important people. The palliative approach to care is both holistic and patient and family centred. And once again, I just reiterate that family describes anyone who the patient considers to be their family. So that could be a friend that's become the most important person to you. It could be a partner, it could be children, it could be, I don't know, just a neighbour. Often neighbours are a really important part of care, and the community. And those who share emotional bonds, common values, goals and responsibilities and contribute to the well-being of each other. So the last, I think this is the last one, but myth 4 is about the fact that often people think if they're referred to palliative care or the words palliative have been used in relation to their care, it means that all the active treatment stops. So perhaps there is not a curative treatment option. However, active treatment also is aimed at ensuring that illnesses and identifying and treating sources of illness and promoting recovery. Palliative care aims to promote comfort and optimise quality of life. So we're focusing on living well with worsening health rather than curing and recovery. It can be definitely provided, palliative care can be provided alongside that curative care. So it could be, we'll use cancer as an example because it is quite prevalent, that you are receiving chemotherapy and other systemic and quite intense treatments, and palliative care can actually support the management of symptoms related to those treatments in collaboration with the specialists. So basically it is that the basic model of palliative care acknowledges the need for an approach to communication about palliative care that prepares for the worst but still allows hope for the best. That, you know, entering a pathway in which the only possible outcome in death is not inviting or might be unacceptable to patients and families, and we very strongly acknowledge that. So, you know, we are very aware that palliative care can be quite can be quite confronting for a lot of people, but we're really trying to work on the fact that this is a side-by-side care when we're coming to treatment options, and obviously really with focusing on patient wishes. So
just quickly, Peter, I just got
yeah, of course.
From the chat. So thank you, Colleen. I hear the statement that palliative care is not just end of life care, but in my experience, care is only action at the end of life. Can you explain further when palliative care actually becomes engaged with people with incurable illnesses?
Sorry, I went mute. I just came
Right.
off. So look, I guess the difference, and this is probably where we'll get to this a little bit more, in the difference between, I guess, the service I work in, which is specialist palliative care versus generalist. If someone has a life-limiting illness, that doesn't, you know, the prognosis and things could be still be years. So palliative care can be very much a focus of care despite that. And, you know, the specialist services can come and go a little bit in regards to complex symptom management. I think I've missed a point of the question, so I might ask you to repeat again, Luke. Just
Yeah, no worries. So I hear the statement that palliative care is not just end of life care, but in my experience, care is only action at end of life. Can you explain further when palliative care actually becomes engaged with people with incurable illnesses?
Yeah, perfect. So I think I was a little bit on the right track, but yes, once again, we can come and go a little bit, and it's really about improving that quality of life. So from my personal experience in palliative care, and once again, this is specialist, so we're looking at really complicated symptoms and situations. We've had patients like, let's consider MND or something that has a variety of trajectory, and some versions of that disease can sort of have a prognosis of years and others is short months. So sort of factoring that in, we often get involved at diagnosis before there are really strong symptoms, and this might also be with some cancer diagnoses. And then we might sort of, once those symptoms have stabilised and we've felt that there's a good core network of support around that person and they're getting the care provision they need, often we'll step out again and then come back in again if there's other symptoms that sort of increase. And once again, usually from a specialist perspective, we often are referred to ourselves when it's about a 3 to 6 month prognosis is quite a common sort of time frame for referral. And I think this is where that specialist versus generalist is a really important concept, because that primary provision of care, even though it's through a GP, it might be community nursing care provision, setting up that core network of people is part of palliative care, even though it might not be named up as such. I don't know if that answers your question 100%, but I hope it at least provides a little bit of insight on how we approach as a specialist service what palliative care means to lots of different people. There's so many I guess there is so many factors involved in this, because the diseases themselves and the diagnosis can be late. The diagnosis might be really early, which improves, the lifespan, and also improves symptom management from that generalist perspective. Does that?
Great. Thanks, Peta.
Yep. Beautiful. Thank you. And please, I'm very happy to qualify a little bit more if needed. But look, and part of our role, and once again, I'm probably speaking more specialist when I'm focusing on a lot of these palliative care slides. But it is a bit of a generalist approach to palliative care as well. So this is that we are trying to encompass all aspects of care of a patient, excluding direct medical treatment. So this is from a specialist perspective, and I'll go through, we'll sort of, hopefully it'll tie together a little bit at the end when I talk about who is actually part of our service, because we've got quite a group of people and like sort of specialties. So we support the care of the patient when they're receiving treatment. So it could be active treatment, it could just be palliative focused treatment, just to make sure that all aspects of their care and quality of life are managed, and that is the focus. The goals are to address the following issues in the diagnosis. So symptom management, once again, is a core. I could talk about symptom management in a whole presentation, but to sort of summarize, the core ones are usually to do with fatigue, nausea, pain, breathlessness, appetite, sleep. So just to, and then there's others obviously incorporated in that, but there's some pretty common ones that have to be managed or that can cause quite a bit of distress to patients, just for a snapshot of what symptom management I'm talking about. There's also psychological and spiritual aspects of care. So, you see a lot of people getting diagnosed with a life-limiting illness is, I mean, I have not been able to speak for myself, but obviously having seen a lot of it, there's these waves of like how you're feeling about it. There's, they talk about the stages of grief and things like that, and I don't necessarily love that whole process, because it's not a linear space. But those psychological aspects of and spiritual aspects of care are really important. It's a bit of a core about who that person is. And obviously we want to support that they want to focus on treatment, and that's a really good goal for them, and helping manage the side effects of some of that treatment as well. So this is where we work in collaboration with other specialties. So it might be oncologists, it could be respiratory specialists, renal facilities and specialty services, and obviously the neurology services as well. We're working out quite a collaboration with all of these groups. Then just as a little point, death literacy is quite a strong core of what we do as well, is trying to engage with people about navigating healthcare. I will say a lot of people don't know how to navigate, and some days I have to admit, even I struggle to navigate healthcare systems and provision of care. It's quite a frustrating space at times. We do a lot of support in helping to plan what might need to be required at the point of death when we're in those conversations with people. So that might be things like helping support how to access funeral services, and then finding information on palliative care generally. I think Palliative Care Tasmania and Australia have become a really core group to find access to the information that's required, and certainly helps point in the right direction, which has been really helpful. But, going on to say government websites or just looking up some of those core things, it can be quite difficult to find the right care and who the people to contact are. And I probably would say that's not just about palliative care, but just healthcare in general, I'd say. So what is palliative care? So the core of it is high quality care and support people living with a life-limiting illness and their families. Once again, helping to live as well as they can by managing pain and symptoms to ensure quality of life is maintained as the illness progresses. Identifying and treating symptoms and issues associated with the life-limiting illness, which can be physical, emotional, spiritual, or social. A family-centred model of care, meaning family and carers can also receive that practical and emotional support. And on that note, I would also like to say sometimes as a service in a specialty area, we consider the distress of the carer and the family and those people to be a core part of assessment, and we have direct support links with them as well that may be not related necessarily to the patient, so we can do separate support and input with family and carers as well. So palliative care is also about maintaining quality of life, and we're not there to hasten or postpone death, but rather focus on living as well as possible for as long as possible. So this is just a little snapshot. It sort of talks through some of the points of what benefits palliative care and sort of that palliative focus of care and input from palliative services can produce. We've sort of talked through most of it, but just to mention things like care coordination is a bit of a core role, advanced care planning, and once again, support for caregivers, and then a dignified end-of-life care focusing on patient wishes. So I feel like I'm repeating a little bit, but once again, we're just trying to reiterate that focus on relieving suffering and quality of life, aiming to maintain some normality, informing and reassuring patient and family about the process of dying. So a lot of our role is to educate, reassure, talk through, answer questions, provide some expectations of what you might expect when someone is dying, because that's a very scary part of particularly being a carer as well. And in the community, which was my area before I became the manager, I was in the community sector. So I used to go out to see people at home and help them plan their preference if it was end-of-life care at home, to try and put that plan in place and explain what that might look like. We also help facilitate patient, family and clinician discussions, ensure patient and their loved ones have a support network, which is extremely important, and facilitating that transparent and honest conversation. So we are looking again, and this is a slide that was sort of about myth 2 and that most people with cancer. So these are the sort of diagnoses where, well, obviously it's not all of them, but some of the core diagnoses that we see as referrals to our Specialist Palliative Care Service. So yes, cancer is our primary one, but we see a lot of chronic obstructive pulmonary disease, or COPD. Along that, things like pulmonary fibrosis is one that we see quite a bit, and other chronic respiratory diseases. Heart failure and other cardiac disorders are also probably becoming a little bit more prevalent, I've noticed, in the last few years. Dementia is certainly becoming, and that would include things like Alzheimer's and all other sort of neurologically degenerative disorders. Motor neuron disease, we certainly have a reasonable number of referrals per year. So that's something, and I know there's a lot of awareness about MND out there. Kidney disease is also another quite a common one that we come across. Parkinson's, and then there's things like stroke. So with those, we're very much a look at the disease process, look at the individual, look at what's going on for them, and we do a lot of what we'd call prognosticating to try and figure out and make sure we're getting the right plans in place for everybody. So you can sort of see some of the common illness trajectories. The acute one on the left is something that's not anything like a palliative or something that we see in specialist, but we've got things like on the top right, there's a short period, so it might be that there's a really aggressive cancer diagnosis, the treatment options are limited, and their trajectory is remaining quite stable for a while, and then the disease really progresses rapidly and death is quite quick. Bottom left is more your chronic illnesses, so you see that sort of general decline in function and health, and then you'll have those little blips where, and a lot of the time, say for example, if it was a respiratory disease where that drops really suddenly, it might be an acute infection. Often it leads to a hospital stay with some antibiotics, and then they sort of gradually come back to almost baseline, but on that downward trajectory. So, you know, that's one where there's chronic symptoms, can be really difficult to manage and support, but usually need a little bit more long-term input from a palliative care service to manage symptoms and help support care at home. And then you've got more the frailty and dementia pathway, which is a continuous, fairly rapid decline, but with less of those more acute changes or exacerbations. So these are we call these the phases or stages of palliative care. So the stable phase is when we've got good symptom control, we're maintaining a reasonable quality of life, they're functionally relatively stable. Unstable is a phase that we don't like very much, so it might be a rapid change or a new symptom, which means that there needs to be a fairly critical input to make sure that we can get that stable, that symptom managed and stable again. Deteriorating is a bit of a tricky one because a lot of the time everyone's deteriorating to some extent. But, you know, we're just managing and hoping to maintain that symptom and comfort and that holistic care. And then the terminal phase or end of life phase is usually when death is likely within short days, maybe to a week or so is when, so that's sort of that last phase. And then bereaved is follow up for family and loved ones. So the next bit is, where is palliative care provided? So obviously there's the ones that probably everyone knows about. There's home, in an acute hospital or inpatient facility, residential aged care or other facilities. So it might be a group home with or something like that where there's care provision. And then finally there's a specialist palliative care unit or hospice style care, which is managed by a palliative care core group of people in Tasmania. And I think, oh, here we go. Yes. So this is more the logistics of what our service is and who we've got available. So Palliative Care North, I've got a map of the area too, so that'll explain a little bit, but we cover quite a few different sectors. So in the middle there, we've got lots of medical. We've got 3 consultants now, which is extremely exciting for us. So Dr. Odette Sprite is our medical director and she's a staff specialist as well. We've got Dr. Glanger and we've got a new consultant come in from the interstate and just started with us, Dr. Gleedle. Then there's myself as manager, Alice as the CNE or educator, and then we've got a couple of admin people. So if anyone's calling in, they're our first voices that people talk to. From there, we extend out into a few areas. So Melwood, St Luke's. So St Luke's is a private hospital here in the north of Tasmania, and one of the wards there is called Melwood. And as a service, or the THS, we actually manage some palliative beds there. We can manage some public beds, which we've funded, and obviously if there's private admission options as well. So that unit is run by our consultant doctor. So full medical cover is by a palliative care specialist with a registrar supporting them. We've also, in the last 2 years, been having some core input into aged care facilities across the north of Tasmania. I think last count we are engaged with about 27 facilities, give or take a few. So that is in reach to help support palliative care and looking after aged care population in supporting the facilities. It can include education of care providers, working with GPs on symptom management and identifying deterioration, unstable patients, terminal patients. And we have a registrar and a clinical nurse consultant that provide in reach, and that's physically go to the facilities, do needs assessment, visit patients, and provide palliative advice. We also provide support to the district hospitals. So there are 7 or 8 facilities in the north, and they have specialised palliative care beds. we don't admit to those beds, but we certainly provide a lot of support and in reach to those facilities as well across the north, sorry. So we don't have anyone dedicated just to that role, but it could be the clinical nurse consultants in the community. Also, our medical doctors do go and visit and meet with those facilities. We've also got our acute hospital in-reach team, which is a registrar and clinical nurse consultant cover with a consultant support, a specialist support. And then finally, we've got our community team. We're now open 7 days a week. Weekends and public holidays are just for phone advice, but otherwise we've got a group of people that manage patients that are at home, provide home visits, symptom assessment and support the primary providers across the north. With that is a multidisciplinary approach with occupational therapy and social work. Also, if it was needed, our medical doctors will provide visits or consult with patients in the community as well. And then our other important group is our volunteers. So we've got 2 coordinators with the service, but I think across the north we're averaging about 50 volunteers at any given time. And they provide a really important work, such as providing some transport, in-home respite. We do a program called Walking Through Grief, which is for the bereaved who come and meet with others who have been in similar situations, go for walks, meet up and create some networks that way, which has been a really, really great service. So that's our people. And now I'll show you what we cover. So they're the areas we cover, but this is the actual geographical location we cover. I drew that blue line. It's terrible. It's not quite accurate. I'm really sorry. I tried to do it with a mouse. So if you look at it, we do cover Ross down in that bottom corner. So if you went from Bicheno through Lake Leak to Ross and then up to Mole Creek, that's our catchment. We also cover Cape Barren and Flinders Island as part of our catchment area. And this is why one of the reasons the specialist service is what we'd call a consultative service. So we don't do the hands-on care because we cannot cover that big an area from here with the 5 or 6 nurses that we've got and other providers. So we really work closely with the community nursing services. I'd say they're our best friends actually and the best friends of the patients. We work closely with the GPs in each area as well. So a real core part of our job is helping support those really primary providers as much as possible. So yeah, it's quite a big geographical space and we've got a lot happening in there. It's a nice little concentrated group of health providers and services. Then just to talk a little bit about specialist versus generalist. So this is a classic triangle approach. I've got a much cleaner version after this, but basically there are levels of care. Level 1 and 2 is where even if it's palliative care, like a palliative approach, the care needs are 100% met by their primary providers, which includes GPs, community nurses, and it might be other care providers such as in-home respite services, ACAT, My Aged Care, and so on. From there, we get up to levels 3 and 4, and this is when their situation or the disease process, the client has some complex needs. This could be complex symptoms, psychosocial needs, social situations, incorporating that spiritual care provider complexities. So once again, we don't actually take over the full care of the patients. We work in collaboration with those primary care providers in whichever region the patient is. When we get to level 4, this is when it's a complete, mostly the Specialist Palliative Care Service provides all the care. And once we get to that level, it's usually an admission to an inpatient palliative care unit or a hospice, where the specialist service is responsible for the full care of that patient. So the next one, I like this one a little better just because it sort of says it a little bit clearer. So the non-complex is generalist, then intermediate might be when specialist advice is needed, and then the really complex is when primary care is involved but specialist palliative care takes on a more lead role. Hopefully that is fairly clear. Don't know if there's any questions coming up there, Luke, at all.
I've got one here that might not relate exactly to the slides that you just went through, but I think it might be nice to still go through. Um, from Mackenzie, I'm just wondering with community palliative care whether that includes assisting clients with personal care in their home. Thank you.
Thanks, Mackenzie. Unfortunately, no, we don't have the capacity to do the actual in-care home care. What we try to do is coordinate the provision, like getting those services in place. So this is a really, it's a big gap in provision of care in the community in Australia, I'd say, that there's just never enough care to support the needs. So 24-hour care, we don't have anything available like that. So if someone needed something like personal care, we would do the usual referrals through My Aged Care or ACAT to get those service provision in place. There's a few ways to get gap cover. So say, for example, they'd not had any services and we were doing a referral. We would use, care gateway to get some interim services and try and support those needs if they were critical. If it's towards the very end of life and it's really urgent input, there is a supplementary service called End of Life Care Supplementary Service that funds additional care. Unfortunately, that care is still provided by the available services. So I think that's probably one of the most frustrating spaces, I think, not just in palliative care, but in community care, is the access to provision of, those care services. I know a lot of the community nursing service will have what's called a HCA or home care assistant that can go in and do some hands-on, washers, showers, personal care for patients. Yeah. But yeah,
Thank you.
sort of one of our frustrating areas. Yeah.
There is another question from Shirley, and you did answer it, but you might want to just maybe close the loop on it a little bit. But Chap Lacey services are working closely with staff at the Mersey Community Hospital. Does the North mean Northwest as well? Probably answered it with the map, but maybe if you dive into that
no,
a little bit more.
it's a good point actually, Shirley. So the Northwest, let me go back actually to the map. So there's some what we'd call the grey area. So where the line basically is where we might actually sort of negotiate with the other services as to who covers. But Mersey, Latrobe and sort of around to Burnie, etc., that's officially under the Northwest catchment. So I guess I probably should have explained this at the beginning, but there are 3 specialist palliative care services in the state. It's North, Northwest and South. So we do communicate, we talk. It is a statewide service, however, we are separated into those catchment areas. But we might sometimes patients across, so there might be patients, say, if we were looking down at Coles Bay, but they're coming to Launceston for treatment, or it might be the other way around, they're in Mersey but coming to Launceston. We might see them when they're in the Launceston General, or if they're coming in for treatment, we might consult with them. But their primary palliative care service would be the Northwest. So yeah, hopefully that answers that a little bit. But yeah, once again, we communicate quite a lot between the services.
Yeah, great.
Which helps.
Thank you.
Yeah. So after I talked a little bit about specialist versus generalist, and once again, it's not a black and white topic. There's sort of variations on that. And as I said before, sometimes specialists and generalists cross over and then it comes back to generalist and we come and go a little bit as needs. So our service and our involvement with palliative care patients is very much on a needs basis. We try not to take over care or step over what the primary providers are already doing because they're excellent palliative care provision. So we sort of jump in when it's becoming a bit more complicated. So when to refer patient to specialist palliative care would be for assessment and advice for managing complex symptoms, to support practical end-of-life care planning, to make sure the needs of the patient are met. And if they're identified as some needs not being met, sometimes we'll get involved to help manage and coordinate and then step out again. Support to meet the needs of the patient's family or carers' needs. And then there's emotional or bereavement support. And on that note, sometimes we will not have involvement in the patient or the client's care, but we might get referred to follow up with the with the bereaved afterwards and provide some emotional support either through our social work or volunteer service. Sorry. So the criteria for referral, it's fairly generic, but obviously they have to have been diagnosed with a life-limiting illness and have complex symptoms or other needs. They have to consent, so that's a really big part, is that they have to agree to being referred, or the responsible person has to agree if the patient doesn't have capacity. So I know that sounds silly to have to put on a slide, but it is actually really important, because the way palliative care and the idea of a referral to palliative care is approached can completely change how that person feels about input from a service and that focus of palliative care. And obviously they have to be aware of their diagnosis and preferably sort of what their prognosis is as well as part of that criteria. So once again, is how to refer. There's that formal, obviously there's a referral. They can, once again, I think we've already talked about this, that there's a life-limiting illness, they're aware of it and have agreed to be referred. If the person is a child or doesn't have capacity, we need to have a responsible person to consent. And once again, we appreciate really detailed referrals. As a general rule, we do like to get referrals from and at least have the oversight from a medical person, whether it be their specialist or their GP, because obviously that's important that they're on board with that referral, and I'm happy to work in collaboration with the palliative care service. And as a general rule, if their ongoing nursing is required, we really encourage that community nursing services are involved. There is a link there, but I've just popped in the actual referral form. So a little bit more, so I must have moved that down a little bit. Once we've received a referral, and I'll just run through this fairly quickly, we have a clinical nurse consultant. We call it the duty nurse. I don't know why, but it's just always been that. That person reviews all the referrals that come through to the service, collects as much information as we can, background, treatment options, what they're having, any comorbidities and background information, if we have medications, etc. So we try to do quite a comprehensive collection of information as part of what we call our triaging process. So that clinical nurse consultant is responsible for triaging the referrals, but we do it in collaboration with our medical specialists and the rest of the multidisciplinary team. So I've just popped up one of the triaging tools that we use. The reason why I put this one up, because it really focuses on helping us categorise how quickly to see patients or to make contact. So really, you'll notice in there's a lot of the word distress. So we go off what's distressing to that person or their family, and how that scores helps us identify how quickly we need to go out and see them. In those bottom two, it could also be a way to identify if they might need to go into a palliative care unit for a review. But this is just one of the many tools, and obviously we use a lot of clinical judgment and that multidisciplinary team approach to talk about how and when we're going to go and see people and make that contact. Once we've sort of done that side of things, so more the paperwork and sort of collaborative side internally, we usually reach out to the client or their next of kin, depending on who's put down as the preferred contact. We provide a little bit of information about the service, sort of discuss to them what their primary needs are at the time, come up with an agreeable time to make a visit, and make sure that we're taking the right people. All patients, particularly in the community, are allocated to a nurse, and they sort of, I guess we'll use the word case manage that client's needs and ongoing input. We will do visits, and we try to organise face-to-face appointments, within that triaging category. So we can meet people at home. Sometimes they might live quite a way away from Launceston, which is where we're based, but they might be coming into the LGH for treatment. So sometimes we'll coordinate that when they're in town for treatment, we might meet up in the office, or we might go see them in Holman Clinic. So we try to make it as practical for them as well. A lot of people have so many appointments that adding another one to the list is just too overwhelming. So we try to match up with what's going on for them as well. We also get quite a lot of referrals now in the aged care facilities. So we do a lot of in-reach there. So those visits will be directly with the facility. We try to incorporate family and next of kin into every visit if we can. And it might be also in-reach into inpatient facilities. And that also includes any district hospitals or private hospitals as well we receive referrals from. Other outcomes that you might find from referrals is if it's primarily about a complex symptom, we do run clinics. Our specialist doctors run clinics. So sometimes we book patients in for that to be seen and have those symptoms really well managed and the oversight from a specialist. Sometimes on referral, we can sometimes get really late referrals, or the patient's had a really new rapid diagnosis of something that's very aggressive. And sometimes that does mean that an admission to an inpatient facility is required. That might be a hospital like an LGH or acute hospital, or it could be the Melwood unit. And just to sort of mention, when it comes to palliative care units, we don't just admit for end-of-life care. In fact, most of the time we admit for complex symptom management, a review of medications if they're really complicated. So that's probably one of the other myths when you're talking about palliative care and it being just at the dying phase. I think admission to a palliative care unit also brings that up for a lot of people. So we try to really reassure that often there are complex symptoms and really complicated medication regimes that need to be consolidated in a facility under specialist guidance. And that's one of the reasons we often admit to the palliative care unit. It might also be that some of the complex needs aren't clinical at the beginning. So it might be that we get social work, we get OT out, or occupational therapy, sorry, or it might be that they just need that bit of support with transport or just someone to come and spend a bit of social time with them. So the volunteers might be the first sort of group of people that get involved. So it's quite sort of not fluid in the way that the service engages with people. And quite often the outcome will be referrals to other community services. We like to try and pre-plan. So we like to get community nursing involved. We try to get referrals to get those care providers in. So your personal care, a bit of home help, and try and get those referrals actioned before the need is urgent. So a lot of it is trying to coordinate that care and make sure things are in place for when condition deteriorates and things like that. So we try to be a little bit forward planning as much as we possibly can. Now, before I go on to the next one, I will just double check if there's any questions on that because this is quite a different focus now.
There was two questions that came through, but I think both from one from Catherine, but I think you answered it throughout that slide. There is one from Colleen. Is it the clinical specialist or patient and their family who are responsible for approaching palliative care services?
Oh, that's a really good point. So as a general rule, we hope that it's the specialists that would make that contact. However, there are times when the patients reach out to us first and we're very available to have those conversations with people. So sometimes it's just that they're not sure if it's the right time and people just need that little bit of reassurance and to talk through what's going on. If that's the case and we think that they definitely need some input from a palliative care service, either we'll recommend that they go speak to their medical provider, whether it be a GP or specialist, or alternatively, we might reach out to that specialist as well and say, look, we've had this contact and it sounds really important that they get involved with us. But once again, it's about managing some of those professional relationships as part of that. So making sure that we're really focused on what the client or the patient needs and their family. So there is a way, we sort of call it a self-referral, but once again, because of the consultative model of the service, we really need that medical sort of buy-in as well and that collaborative approach to care. But we get calls from all sorts of people just asking. Sometimes it's just they want to know a little bit about what's available, and other times they just need some reassurance and someone to talk to. Some of those those contacts could end up becoming what I'd call more of a social input from the service. So it might be that we've got someone in like a lot of distress, but from a clinical perspective, they're not needing much from what I'd say the clinical side of our service, but they might get involvement from social work or once again, those volunteer services and social supports. Yeah.
Great, thank you. And one from Mackenzie, which is, do you offer VAD or assist with it?
Yeah, look, it's become a much more common question. The short answer is no. We have no involvement in the VAD process, nor do we coordinate or help plan with any of that. However, being part of a collaborative approach to care, we are certainly allowing people to, we're focusing on their decisions. So if they ask us about VAD, then we point them in the direction of the VAD navigation service, provide them the details to sort of work through that with that service that specialises and works them through all of that. Yeah, so it's we're not sort of due to conflict, we've got to be really careful how we approach that, but we certainly let the patient guide what they want to focus on, and then we just support with getting them in touch with the right people.
Yeah, great. Just on the back of that, Mackenzie, our next speaker series actually is with Anna Mayo. So I'll do a little self-promotion there, but if it's in November, I think the 21st, we'll go through that slide in just a moment, but that would be a really great one to attend and seek some more information from there, and maybe even ask that question again. But that's with Anna Mayo, who is the manager of the VAD Commission. So selfless plug there, but I'll give it back to you, Peter.
That's perfect. Great timing. Yeah, I'm just trying to think. I felt like I had something else to say about VAD, but it's left me, so I'll leave it. But once again, we've also got really good contacts with, like, we don't know all about it, so if we have questions, we reach out to the navigation service as well. So, you know, it's a very, very collaborative, once again, a collaborative approach with all specialties, whatever that might be, with that ongoing focus on the patient's wishes. So this is sort of towards the end of things. I just wanted to sort of give a snapshot of, well, it's really just about numbers at the minute, but just to give you an idea of what the future of palliative care in Tasmania specifically, but Australia, is sort of predicting for, like, say, the 2030 mark. So we're sort of looking at that 10-year workforce plan. As of last year, there were over 5,000 deaths in Tasmania. I did some calculations, and I will say that my access to data and how accurate that is, give it a little leeway either way. But from my calculations and stats, there were over 1,000 that were registered with a specialist palliative care service. So it's obviously a fifth of the deaths. With the Palliative Care Tasmania report, there was estimated that 3/4 of the total deaths in Tasmania would have benefited from having palliative care input. It doesn't specifically say specialist, but that palliative focus of care. So that would have been about 3,800 people. So, and they didn't all get that access to palliative care, I don't believe, but basically what it's showing is how important the palliative space is. And this is the reason why palliative care is everyone's business now. The future of the population increasing to about 30 million predicted by 2030. They say that the population over 85 is also going to increase. I can't remember the exact stats on that, but it was significant by 2030. With that comes the increase in sort of those comorbidities and chronic conditions. There's an increase in dementia. Overall, there's about 10 to 15% annual increase in workload. I'm working from specialist palliative care, but that leads on to probably even more for the generalist sector. So I've just popped some numbers in just from our service data. And you can sort of see that between 2021 and 23, probably the big jump was from 2022 to 2023. We had that 10 to, I think it was about 12% increase in both referrals and deaths. And then our prediction for this year, because I've already got the stats up until the end of October, is that overall our referral numbers will be getting closer to 970. When you look at 2021, it was 730. So we're really seeing a rapid increase. Part of that could also be just the fact that we're getting more, people are a little bit more aware of palliative care, that the purpose of palliative care is becoming a little bit more well known, so the referrals are going up. We've also been working really closely with a lot of specialties and increasing our presence to care providers, so hopefully that's also a part of that. But the reality is it's those other factors of aging population, increase in chronic diseases, increase in some of those neurodegenerative diseases and cancer diagnoses. And you can sort of see that the referrals and the deaths totals correlate quite closely. So yeah, it's an increasing workload. And I just think it's really important that we're all aware of it. And this is where I guess part of my passion for primary health and palliative care is that palliative care isn't just about paid care providers. In fact, one of the things, and this is anecdotal, but one of the things I saw when I was out in the community is if you had a group of people around you that were able to provide that care in the home, that's how people can stay home and receive palliative care at home. So the community, families, care providers, friends, neighbours, it's just a huge part of actually being able to provide good palliative care. And it's a bit of a scary thing for people to do, but I've seen some incredible families out there and people with just a neighbour that was so attentive and helpful, and that's what made the difference in being able to stay home. And I just think it's quite incredible that it's about the people. I've left some details. This is just our general contact details for palliative care. I've done the North the biggest because that's where I'm from. But yeah, we're also always really happy just to have people call us and ask questions, or if you need some advice, our phone's always open 8:30 to 4:30. And yeah, I guess basically the process is knowing what your wishes are, knowing what your clients or patients' wishes are. It's about who and what's important. And this is another key point. It's not about what you think quality of life looks like. It's about what quality of life is for them. And that's how we've got to focus how we approach people and patient care. And existential distress is a huge part of this. So let's not forget that the mind and body are the same, and you've got to look after both. And oh yes, the National Palliative Care Standards, I have to pop them in there. But look, I think I've put some resources up. I'll leave that there a little bit because this will be filmed. So if anyone is interested in other things, there's some excellent TED Talks that I can highly recommend. One of them is by Ken Hillman, and it was TEDx in Sydney. This is, I think it was about 8 years ago, but still very relevant. And he talks about we're doing dying all wrong. And now he's an intensivist in intensive care. So it's pretty important coming from someone like him who sees like lots of variations on what death looks like. And then yeah, there's lots of resources from Palliative Care Tasmania, National Standards, Palliaged Home. There's Care Search, lots of different places. I won't go through all of them, but basically there are a lot of resources out there if you know where to look. And yeah, I think I won't talk through all the slides anymore because we're pretty much out of time, but I'll leave it for questions. But I really appreciated that it happened during the talk because, yeah, we could stay a bit on topic then. So thanks, Luke.
No, that's great. Thank you, Peter. And we do have a few other questions, but before we do sort of open up the chat for a Q&A, I just want to thank you for your time. And I know you've got a very busy schedule. So to pull you out for an hour is something that I'm PCT, and I'm sure the audience are really grateful for. As I said, the chat, the Q&A function is where you want to pop your questions in. So if you do have any other questions, we'll sort of maybe have about 5 minutes. So if anyone does have any questions, please just pop them in there. There is two just that were asked during the presentation that I didn't get to. So one of them was being able to provide the slides for this training, for this session. So I'm not sure if that's something that you're comfortable with, Peter, or maybe we can condense it down and give some of those. I think those additional the resource slides would be really helpful for those who wish to receive it. So I'll send out an email to those who attended today and registered. So you will receive some bits of information and some resources and some links to YouTube's resources. So that will go out. And then just another question from Catherine, which was, is there a waiting time to access PAL care or palliative care?
Once again, I'll focus on specialist palliative care because I guess we are the palliative care service and everything else is more generalist with those primary providers. So, and this is where that triage comes in and is really important. So it's not the same as ED, but it's sort of about focusing on who has the most complex needs and urgent needs. As a general rule, and I don't have the stats to back this up, but we try to see people no more than 2 weeks out from referral. If between that time, usually we've been in contact within 3 days. So the first phone call contact to sort of help coordinate input is quite quick. But as far as actively getting into the home, it could take that little bit longer dependent on need, but there is definitely contact quite quickly. There is also, like, sometimes we do get referrals that are not appropriate for our service. It's very situational dependent, so I can't really go into specifics of that, but sometimes it's because a complex need is chronic pain and we can't manage chronic pain patients. So, there's some things like that. So there might be the point where a referral isn't accepted, but we usually try to feed that back to the referrer quite quickly and point them in a direction that might be more appropriate. It's not that common, but it can happen that way as well. But yeah, as far as wait time goes, I would like to suggest that contact's made quite quickly via the telephone, and then active input or face-to-face visits, I would average 2 to 3 weeks if it's non-urgent.
Great, thank you. There's a few people in the Q&A that are just thanking you for your time and presentation. So just reiterate that. I've got a question. I might even have two, see how we go for time. But one of the questions is, no, we'll combine them. It might be a nice way to combine them. So for the service in the North, what are, I guess, you would say is your current biggest challenge, the biggest hurdle that you consistently see? And then it doesn't have to be innovative, but one of the biggest strengths that you see from your service? From the presentation, it sounds like the collaboration piece is probably one of the big ones, but just sort of from your perspective, one of the biggest challenges, whether that's something that's happening now or in the future that you can sort of can foresee, or and one of your biggest successes or strengths of the service.
It's a bit hard to sort of say the biggest one, I suppose, but obviously one of the big ones is the fact that this is an increasing space, so that we know that the workload's going to be increasing quite quickly, and we're already seeing that effect. So that's also always on the mind, and sort of thinking about how do we forward plan for that. So I guess that part of our strategy for that is, once again, building those collaborations with specialists and other services. As far as difficulties go, sometimes it can be engagement from all collaborative parties. So that engagement in palliative care and trying to coordinate, being consultative has its own issues because we can't take over the care from a primary provider. So if we feel like the care isn't, or that's, I'll throw it back to, say, a medication isn't the right one for that symptom, for example, I'll make it a bit of a practical version. It's very difficult and can be quite challenging to try and utilize. It takes time and lots of contact and lots of support to try and get through the point of why we're wanting to change something, and getting that action. So I guess time is a big factor and a big barrier sometimes. It feels like we do a lot of collaborating, a lot of talking, a lot of advice, and spend a lot of time trying to just get the outcomes that are going to work the best for the patient. Knowing that everyone's got their best interest at heart is just a different approach.
Yeah. Great.
Does that sort of, hopefully that makes sense?
Yeah.
It can be.
And then biggest success, not biggest success, maybe like something like your proudest, I guess, or something.
Yeah.
You see as a
Oh, look.
service. I'm sure there's so
I
many,
think
but maybe just
overall, I think the last 2 years our service has seen retention of staff, which has been incredible. I've been here for what must be seven years, I think. And I started when the service was quite small. We've gone through quite a lot of change, and over time we've built up to have a really core group of staff. With a lot of course, lots of improvements. Everyone can grow and improve, and we're seeing that drive and that passion to improve the service. We've also had really solid medical staff, which has been incredible. So that really the strong cohort of medical staff who are staying and are passionate about Tasmania and palliative care. And they've been core in, like, we're working on projects and research now. Like, we're really focusing on growth. And we've got quite a few projects happening. So the InReach into Aged Care, which is in the last 2 years, that's a national project. However, like, just seeing that actually in place and realising that it's so important and must stay, we're really lobbying for that. So there's a lot of work happening in the background to maintain services that we've currently got. We are also running education sessions for medical practices. So we're doing what's called an ECHO project. So we're doing really, really active outreach. And I think, to me, that's the biggest thing that's been happening recently, is like we're getting seen a lot more. We're participating in a lot of collaborative care. We've got really, really well-respected medical staff that work here now. And that's bringing a lot more, this is it's not right. It's bringing a lot more oomph to the service, like a little bit more. I can't think of the right word, but you know what I'm trying to say.
I'm picking up
more.
Yeah.
Yeah. So it's been really nice to see that. And, like, genuinely, we built a group of really, really caring people. And it's just been quite incredible. We've got registrar programs now. And one of our biggest things is we are now fully accredited to do advanced training in palliative medicine.
Great. Thank you.
Which is incredible. So anyway, there's a lot more. I can brag for a while, but yeah.
Well, given the time, I might close the Q&A session, and just want to, in fact, I might even just quickly share my screen just to sort of quickly go through a few slides, just to thank all the members who, our PCT members who have joined us here today. If you've enjoyed today's event, the best way that you can support palliative care is to become a member. It's a really quick process. You can scan the QR code or jump on our website to sign up today. As part of the member benefits, the recording of today's session will be sent out to you, and you'll have access to that at any point. So please consider becoming a member. We really appreciate everyone's participation today, and would really hope that you all found it very valuable. I know from the Q&A chat, it sounds like everyone really enjoyed today's session and got something out of it. So again, thank you, Peter. But if you want to stay informed about our upcoming and online events, please jump onto our website. You can visit our events page, where you'll see all the events that are coming up for the remainder of this year and some of the events that are starting next year. I also encourage you to scan the QR code and complete our survey. It is really important that you provide your feedback, so we know what speakers to get in next time and how we can continue to improve. So you will receive an email later today with a link, but if you want to scan the QR code and complete that now, it's a really short survey. I promise there's not too many questions, so spend 2 or 3 minutes completing that, please. And as I mentioned before, if you aren't already aware, our next speaker series will be held next month on Thursday, the 21st of November at 11 a.m. And we'll be joined by Anna Mayo, who is the manager of the Tasmanian Voluntary Assisted Dying Commission. Again, you can scan that QR code if you've got time now. Otherwise, visit our website, and I'll also send you a link via email that you can register today. And just finally, the nature of our topics we discuss can sometimes raise complex, powerful, and raw emotions. So I encourage you all to keep checking in with yourself today. Take 5 minutes to really just go for a walk and get a breather and ground yourself if you need it. And just again, thank you, Peter, for your time and for your engagement. And really hope that you enjoyed today's session, and I hope that everyone that jumped in as well found it valuable. And I hope to see you all at our next speaker series.